So today's topic is vitiligo. Vitiligo মানে হচ্ছে তোমার সেতি রোগ, তোমরা জানো, ঠিক আছে? What is vitiligo? Vitiligo is an acquired pigmentary disorder affecting the 0.5 to 2% population worldwide, in which there is complete loss or destruction of the functional melanocyte or absence of the functional melanocytes. You know the melanocytes are present in the basal layer of the epidermis. Do you know the layers of epidermis? From the superficial to deep, 4 layers are present usually: stratum corneum, stratum granulosum, stratum spinosum, and stratum basale. In basal layer, the melanocytes are present. So why melanocytes are important? Because it produces the pigment melanin, and it usually gives the color of the skin or produces the color of the skin. In vitiligo, there is usually destruction of the functional melanocyte, leading to the complete depigmentation of the skin. So in vitiligo, it is an acquired pigmentary disorder affecting only 0.5 to 2% world population, where there are absence of the functional melanocyte, leading to the depigmentation of the skin. Family history is found nearly 25 to 30% of the cases. On 30% family history is present. It occurs in both the sexes equally. Equally, that means male and female both can be affected. And less than 10% chance to develop the vitiligo in the children when the both parents are affected. Less than 10% chance to develop the vitiligo in children when the parents are affected. Disease usually does not do any harm to the internal organs, but it produces a lots of psychological distress to the patient. That means it produces a lots of anxiety or depression to the patient. Though it doesn't produce any harm or any injury to the internal organs, but it produces a lot of psychological distress because of the appearance. So patient usually suffers from a lot of anxiety or lot of depression because of this disease. Now coming to the etiopathogenesis. Till that there is no precise etiology of pathogenesis. There is both genetic and non-genetic factors are responsible for the causation of the disease. The etiology and pathogenesis are mostly complex and inherited with the both genetic, immunological, neural and self-destructive mechanism. Genetic, immunological, neural and self-destructive mechanism. There are some hypotheses which are related to the vitiligo. That is the most important is the autocytotoxic hypothesis and oxidative stress hypothesis. What is autocytotoxic hypothesis? In the autocytotoxic hypothesis, there is production of the degeneration of melanocyte due to production of the H2O2 within the epidermis. And as you know, the hydrogen peroxide is usually toxic to the epidermis, leading to the degeneration or destruction of the melanocyte. And in the oxidative stress hypothesis, there is an alteration of the antioxidant mechanism. There is an alteration of the antioxidant mechanism and increased level of the superoxide dismutase level in the mononuclear cell and the serum of the vitiligo patient, and reduced catalase level in the mononuclear cell, keratinocyte and melanocyte. So there is increased superoxide dismutase level and reduced catalase level. And as there is the increased superoxide dismutase level, this is also toxic to the melanocyte, leading to the degeneration and destruction of the melanocyte. And also there are some autoimmune hypotheses are there. So vitiligo is an autoimmune disease, and most of the cases it is associated with many autoimmune disease, leading to the destruction of the melanocytes. So these are all hypotheses, but exact cause, what is the exact pathogenesis is still not clear to us. Associated disorder. So vitiligo is most likely associated with the many autoimmune diseases like autoimmune thyroid disease, pernicious anemia, Addison's disease and alopecia areata. These are all autoimmune diseases. So vitiligo is mostly associated with many autoimmune disease, that is autoimmune thyroid disease, Addison's disease, alopecia areata, etc. Most commonly association is the autoimmune thyroid disease. So in case of the thyroid function test should be done for the each and every vitiligo patient, because the autoimmune thyroid disease is most commonly associated with the vitiligo. Now coming to the types of vitiligo. What are the types? Usually mostly 6 types of vitiligo are usually come across in our clinical setup. Most important is the localized type of vitiligo or focal vitiligo, lip tip variety vitiligo, or also known as the acrofacial vitiligo, segmental vitiligo, generalized vitiligo, universal vitiligo or vitiligo universalis, and mucosal vitiligo. So focal or localized type of vitiligo. In the focal vitiligo, the depigmented macule and patches are present only confined to a particular site or particular anatomical area. This is known as the focal or localized type of vitiligo. Now coming to the segmental type. What is segmental vitiligo? That is depigmented patches are particularly distributed over a particular dermatome. This is known as the segmental type of vitiligo. Segmental vitiligo is most commonly found in the children. Near about 20% cases of the childhood vitiligo is segmental vitiligo, whereas only 5% of the adult vitiligos are segmental vitiligo. So segmental vitiligo is most commonly found in the children. Most of the cases of childhood vitiligo, near about 20 to 25% cases are the segmental vitiligo. It is usually follows a particular dermatome. And number three is the lip tip variety of the vitiligo or acrofacial vitiligo. In the lip tip variety of the vitiligo, that is depigmented patches of the vitiligos or macules, particularly affecting the lips and also the tip of the digits, tip of the fingers and the tip of the toes. This is known as the lip tip variety of the vitiligo. And generalized vitiligo. What is generalized vitiligo? That is the depigmented patches of the vitiligo is scattered and widespread, affecting more than one anatomical site. This is known as the generalized vitiligo. In our clinical setup, most common type of vitiligo is found in the generalized vitiligo. Most common type is the generalized vitiligo, which we come across in our clinical setup, is the generalized vitiligo. Now, coming to the fifth type, that is the vitiligo universalis or universal vitiligo, in which the depigmented patches are scattered, affecting almost entire body surface area, almost entire cutaneous, almost entire body surface area. It is known as the vitiligo universalis. And now the last type, that is the mucosa type of vitiligo. It affecting the oral mucosa or genital mucosa, that is penile mucosa or vulval mucosa. This is known as the mucosal type of vitiligo. But among this, the most common type of vitiligo which come across in our clinical setup is the generalized type of vitiligo. And one thing you have to remember, that segmental vitiligo is most commonly found in the children compared to adult. Segmental vitiligo is the most commonly found in the children compared to adult. Now coming to the clinical features. কিভাবে প্রেজেন্ট করবে এটা, ঠিক আছে? The vitiligo is characterized by the ivory or chalky white macules or patches affecting any area of the skin. Any area of the body can be affected. From the head to toe, any area of the body can be affected. Number one. And it is usually mostly asymptomatic. Most people will complain nothing, mostly asymptomatic, only depigmented patches. For sometimes people may complaining of the pruritus or mild itching may be complained. Number one. And depigmented hair, which is also known as the leukotrichia. Depigmented hair is known as the leukotrichia. That means the hair can be also affected with the vitiligo, which bears a bad prognostic sign. Depigmented hair is known as the leukotrichia, which usually bears a bad prognostic sign. Now, this is the picture of the vitiligo. That is the depigmented macules distributed mainly over the perioral areas and the periocular areas. That is the facial vitiligo. It is a type of facial vitiligo most commonly found in the periocular and the perioral areas is the vitiligo or depigmented macules or patch affecting the facial skin. Now, this is the localized type of vitiligo. That means the depigmented patches particularly affecting a particular anatomical segment. Here the chin is affected and also you can see the leukotrichia, that is the white hair. The leukotrichia can also be seen. That is the leukotrichia, which usually produces a bad prognostic sign. Leukotrichia can be seen. Now, this is the type of the a child with acrofacial distribution of the vitiligo. That is the depigmented patches not only distributed over, this is the lip. Lip is also affected in the vitiligo and also the tip of the digit, that is tip of the finger and tip of the toes and also affected. This is known as the acrofacial distribution of the vitiligo. And lastly, the segmental type of vitiligo. As I have already told, the depigmented patches distribute a particular dermatomal skin, dermatome. This is a segmental type of vitiligo. The segmental type of vitiligo, as I have already told, is commonly found in the children compared to the adult. This is the type of segmental vitiligo. And now to the differential diagnosis. So, what are the differential diagnosis? That means what are the some clinical pictures which mimics the vitiligo but not vitiligo. All white patches are not vitiligo. সব সাদা দাগ সেটি নয়. This is the differential diagnosis. What are the differential diagnosis? Most important thing to remember is the first one is the pityriasis alba. What is pityriasis alba? Pityriasis alba is usually hypopigmented macules and patch with ill-defined border, most commonly distributed over the facial skin or other sides of the body can also be affected. Most commonly found in the atopic children and the age group most commonly affected is the 5 to 15 or 3 to 17 years of age groups are mostly affected. So, it is mainly found in the facial skin with a hypopigmented macular patch with ill-defined border is mostly found. This is known as the pityriasis alba, commonly found in the children. Number one. Number two is the hypopigmented pityriasis versicolor. As you have already known that the pityriasis versicolor is basically a superficial fungal infection. It is basically caused by the pityriasis versicolor is caused by which organism? Pityriasis versicolor is caused by which organism? Pityriasis versicolor. Already taught in your class. Pityriasis versicolor is caused by which organism? Which fungi? Is it a superficial fungal infection or deep fungal infection? Superficial fungal infection. Correct. Which organism causes it? Yes? No, no dermatophyte. Which organism causes the pityriasis versicolor? Also you are told in microbiology also. Pityriasis versicolor. Pityriasis particularly is caused by the Malassezia species. If Malassezia globosa or Malassezia farfar or Malassezia restricta, the several species of Malassezia can cause the pityriasis versicolor. There is perifollicular hypopigmented macule coalesced to form the big patches with fine brawny scaling distributed over the chest, back or arm regions, or it can be distributed anywhere. But most important is the perifollicular hypopigmented macule coalesced to form the big patches with fine brawny scaling. So it can, so pityriasis versicolor is basically caused by the Malassezia species. How do you identify it? By doing a KOH mount preparation to identify the fungal yeast or hyphaeal form. Usually KOH mount preparation we can see the spaghetti or meatball appearance or banana or grapes appearance. So both fungal hyphaeal or yeast form can be seen by doing a KOH mount preparation. So it is basically caused by the superficial fungal infection caused by Malassezia species. Now other causes, that is hypopigmented patches of the lepromatous leprosy or borderline tubercular leprosy. In the Hansen's disease, sometimes the hypopigmented patches can be found, but you have to check for the sensation, that is there is obvious loss of the sensation, that is the pinprick sensation, pain sensation, there is loss of fine touch, crude touch, and also temperature sensation, and there is also thickness of the nerve, so the peripheral nerve, which may or may not be tender. The most important thing is the loss of sensory sensation, that is sensory loss, and there is thickening of the peripheral nerve, which may or may not be tender. This is the important finds of the Hansen's disease. Now coming to the albinism. Albinism is a genetic disease which is autosomal recessive condition. Most commonly is occurs due to the deficiency of the enzyme tyrosinase. In that case, the total number of the melanocyte numbers are normal, but there is a deficiency of the complete absence of the enzyme tyrosinase. As a result of this, from the tyrosine to dopa and dopa to melanin is not produced. So there is loss of melanin pigment is not produced due to the deficiency of the enzyme tyrosinase. It can affecting the skin, it can affecting the hair, and also it can affecting the eyes. So people can, and in that case, the people of the albinism cannot tolerate the sunlight, and usually there is also, the people cannot tolerate the sunlight, and also there will be ocular problems. That means it reduced visual acuity, nystagmus, involuntary oscillatory to and fro movements, and also strabismus can be seen, and also the reduced or absent retinal pigmentation can also be seen. So it is present since birth. It is present since birth. Vitiligo is an acquired condition, but albinism is a genetical condition present since birth, and it can also affecting the not only the also affecting the hair, skin, and also the eyes. Also affected, and people cannot tolerate the usually sunlight or bright light cannot tolerate. Nevus depigmentosus. What is nevus depigmentosus? Nevus depigmentosus is a nevoid condition, and jorul ekapar. Nevoid condition. Usually it is a present since birth or shortly after birth. There is a serrated margin, and usually it presents with an hypopigmentation rather depigmentation. It usually presents with a hypopigmentation rather depigmentation, and also the hypopigmented lesion of the post-collagen dermal dispensation of PKDL. Sometimes the hypopigmented lesions of PKDL mimics the vitiligo. And lastly, the chemical leukoderma. What is chemical leukoderma? There are some chemicals particularly used in the bindis or sindoor or some rubber slipper, that is the paratertiary butyl phenol or paratertiary butyl catechols or some chemicals which can produce the vitiligo-like depigmentation. But there is a patterned appearance of the depigmentation, presence of the confetti-like macule, and itching is very much severe in that cases, which can usually used to distinguish, help to distinguish the vitiligo from chemical leukoderma. And also the chemical leukoderma, the repeated use of the particular chemicals also present. That is particularly in case of the bindis, the depigmentation is just like the shape of the bindis, and repeated use of the particular substance is also present. And history of the particular use of the particular chemical, confetti-like macules, these are very characteristics of the chemical leukoderma. So you have to only remember 2 or 3 things, that is pityriasis alba, hypopigmented pityriasis versicolor, Hansen's disease, particularly hypopigmented patch of Hansen's, or chemical leukoderma. If you can say 3 or 4 or 2 or 3 things, that is enough for you. Now the treatment of vitiligo. What is the goal of treatment of vitiligo? The main goal of the treatment of the vitiligo is to arrest the progression of the disease, and repigmentation over the depigmented skin. That means that first of all, you have to arrest the progression of the disease and repigmentation of the depigmented skin. Number 1. Number 2 is that for the localized vitiligo, for both in adult and children, topical corticosteroids can be applied. Usually potent to superpotent steroids are applied, except in the facial skin. Usually we can apply the mid-potent steroid. Usually potent steroids are applied usually for 2 to 3 weeks, and then 1 or 2 weeks steroid holidays are given. And usually this type of cycles are repeated for usually 2 to 3 months or 3 to 4 months to check the result. And if there is no improvement after that, you can switch off to the other treatments also. Now, and the topical calcineurin inhibitor. Topical, that means the tacrolimus ointment, 2 strengths are available, 0.03 and 0.1, and pimecrolimus cream 1%. This can be available. These topical immunomodulators or topical calcineurin inhibitors produces a good result in particular localized vitiligo, located in the facial region, particularly facial vitiligo, it produces comparatively good result. And topical corticosteroid can also be used in conjunction with the topical calcineurin inhibitor to produce the or to get the synergistic effect to get the good result. And topical tacrolimus ointment or topical calcineurin inhibitor can also be used in conjunction with topical steroid. Other topical therapy which can be used is the topical puba therapy. In that case, the 8-methoxysorolene solution in 0.1 to 0.01% solution is diluted with water and applied over the vitreogenous skin, wait for 30 minutes, and then sun exposure is done. Initially for few seconds and then gradually exposure will increase to 10 to 15 minutes, and after that area should be washed thoroughly with the soap and water and should be covered with the clothes or sunscreen. But the most only disadvantage is that it produces severe phototoxic reaction or blister formation can occur. And other topical therapy which can be used for the treatment of vitiligo is the topical JAK inhibitor, that is topical janus kinase inhibitor. The tofacitinib ointment can also be used nowadays for the treatment of the localized vitiligo. So, tofacitinib ointment can also be used for the treatment of the extensive disease in the adult, or if the rapidly spreading vitiligo, if the vitiligo is rapidly expanding, or if it involving the more than 20% body surface area, in that case you have to give the steroids. That means usually the oral steroids are given, that is the pulse therapy of the steroid, that is the pulse steroids are given. Usually pulse steroids are given with betamethasone or dexamethasone or methylprednisolone, usually given in a dose of 0.1 milligram per kg body weight, 2 consecutive days in a week. That means Saturdays and Sundays are given, and for several weeks to produce, so that we can arrest the spread of vitiligo. Usually the mini pulse steroid or pulse corticosteroid produces the good result for the arrest of vitiligo. It is applicable both for the adult and the children. Usually oral corticosteroids, usually betamethasone 4s are commonly used in the 2 consecutive days in a week in a dose of 0.1 milligram per kg body weight in 2 consecutive days for several weeks to make the vitiligo stable. And also other drugs, dexamethasone or methylprednisolone can also be used. But if the patient is diabetic or hypertensive, in that case you can't give the systemic steroid. In that case you have to switch off to the other immunosuppressive drug for the stabilization of vitiligo. Other immunosuppressive drug which can be given as the methotrexate or azathioprine or oral JAK inhibitor, that is oral janus kinase inhibitor, tofacitinib 5 milligram BD can also be used to make the vitiligo stable. So, if there is a contraindication to the oral steroid, suppose the patient is diabetic or hypertensive, in that case other immunosuppressive drug like methotrexate, azathioprine or oral janus kinase inhibitor like tofacitinib can be given, number 1. And lastly, the systemic puba therapy. Systemic puba therapy, but in that case the vitiligo should be stable, vitiligo should be not expanding, vitiligo should be stable. In that case you can give the systemic puba therapy, but systemic puba is only applicable for the children. It should be, the systemic puba therapy you can give for the adults. It is not given in the children because it is not given in the children less than 12 years of age with high risk of development of the cataract formation. So, systemic puba therapy is particularly applicable for the adult. So, in case of the extensive vitiligo lesion in adult, most important drugs which are given is the oral corticosteroid pulse therapy, other immunosuppressive medication, systemic puba therapy and narrowband UVB. These are particularly given for the adults. In case of the extensive vitiligo in the children, suppose in the children the disease is rapidly expanding or depigmented patch is rapidly expanding, or if it involves the more than 20% of the body surface area, in that cases again the oral corticosteroid pulse therapies are given in 0.1 milligram per kg body weight in 2 consecutive days for several weeks to make the vitiligo stable. And systemic puba is not applicable in the children, as I have already told you that high risk of development of the premature, high risk of development of cataract formation. So, narrowband UVBs are particularly preferred in the children. So, for extensive vitiligo in the children, the oral corticosteroid pulse therapy and narrowband UVBs are particularly effective. These are particularly given for the if the vitiligo is rapidly expanding or if it is involving the more than 20% of the body surface area. In that case, the systemic corticosteroid pulse therapy or immunosuppressive drug or systemic puba is given for the adult patient, and for children corticosteroid pulse therapy or narrowband UVB can be given. Now, coming to the systemic puba therapy. How the systemic puba therapy is given or oral puba therapy is given. Oral puba therapy is done with oral soralin. Oral soralin is puba means soralin with ultraviolet A, soralin with ultraviolet A. Particularly, it is usually a patient is asked to take the oral soralin in the dose of 0.6 milligram per kg body weight in 2 days in a week, but not 2 consecutive days. 2 days a week, not 2 consecutive days. That means either, for example, Monday or Thursday in this way, and between 9 AM to 11 AM and after 2.5 hours of intake, vitiligo lesion will be exposed to sunlight initially for 5 minutes, and then gradually sun exposure time can be increased maximum up to 30 minutes. This is for the Oral Soralin 0.6 milligram per kg body on 2 days in a week between 9 am to 11 am. After 2 to 2.5 hours of intake, vitiligo lesion will be exposed to sunlight initially for 5 minutes and then gradually exposure time will be increased to maximum 30 minutes to get the result. But oral puba therapy must be applied for at least 6 months to get the result. Initially, there will be perifollicular hyperpigmentation and then the pigmentation usually starts. But there are many drawbacks of the systemic puba therapy. Most important is the GI side effect. Patient complaining of the nausea, vomiting, GI side effect. And also during the sun exposure, eyes must be protected during or rest of the days with UV protective glasses. That means ultraviolet protective glass should be applied to the patient. Patient is asked to use the ultraviolet protective glasses. And it is contraindicated in the children below 12 years of age and also contraindicated in the pregnancy or lactation. As I have already told, there are many drawbacks of the systemic puba therapy. First of all, it is not given in the children because of the high risk of development of the cataract formation. It is also contraindicated in the pregnant or lactating mother and high chance of GI side effect. And also systemic puba therapy, it can also produce the phototoxic reaction, and the long-term exposure, there is a high chance of development of the cutaneous malignancies also. The systemic puba can also produce the cutaneous malignancy, and it is not applicable to the children below 12 years of age. Now coming to the narrowband UVB therapy. Narrowband UVB therapy, wavelength 311 nanometer. How the narrowband UVB therapy is done? Narrowband UVB therapy is done with the starting dose of 100 to 250 millijoules per square centimeter square, which is gradually increased to 10 to 20% in the subsequent exposure. Usually it is also given in 2 days in a week, but not 2 consecutive days. 2 or 3 days in a week, usually narrowband UVB therapy is given until the mild asymptomatic erythema is achieved. That means the starting dose is 100 to 250 millijoules per square centimeter square, gradually increase 10 to 20% in the each and subsequent exposure until mild asymptomatic erythema is achieved. Narrowband UVB therapy is comparatively safe and lack of side effects are also very minimal. Side effect is minimal. Lack of gastrointestinal side effect, that means the nausea vomiting is also very less, and reduced phototoxic reaction. No need for the photoprotection, no need for the post-treatment photoprotection, no need for further after-treatment photoprotection. Usually therapy. It is safely used in the children, pregnant and lactating mother, and the patient with hepatic and renal dysfunction. So it can be safely given in the small children, and also it can be given in the pregnancy or lactating mother, and also the patient with hepatic or renal dysfunction. Narrowband UVB therapy can be given. So the narrowband UVB therapy is the one of the most important treatment for the more than 20% of body surface involved in vitiligo, both adult and the children, and also in the cosmetically sensitive areas. But the most important side effect is the pruritus and xerosis. Xerosis means dry skin, and pruritus means the itching. There is mild itching or dry skin can occur, which can be easily manageable. So narrowband UVB therapy, and there is no side effect of the formation of the cutaneous malignancies. In the puha, there is a long-term exposure, there is a few reported cases of the cutaneous malignancies, squamous cell carcinoma, but in narrowband UVB, there is a cutaneous malignancy, there is no risk of cutaneous malignancies. This is also important. So it is a comparatively safe drug. Number one, due to the lack of side effect, and also it is safe in the small children, pregnant and lactating mother, and patient with hepatic or renal dysfunction, it can be safely given. And now the other treatment parts of the vitiligo. That is for the segmental vitiligo. As I have already told you, segmental vitiligo affecting a particular dermatomal segment, it usually produces poor response to medical therapy. In that case, the surgical treatment or mini punch grafting can be done. But for that, vitiligo should be stable for at least 1 year, and age of the children should be more than 12 years of age. That is important. Excimer laser. Excimer laser is wavelength 308 nanometer. Excimer laser is particularly helpful for the treatment of the focal vitiligo. That is vitiligo which is depigmented patches particularly present over the face or neck region. Just localized vitiligo. Excimer lasers are effective. So excimer lasers are effective for the treatment of the localized lesion. And also the camouflaging. What is camouflaging? Camouflaging means the different color sets are matched with the normal skin and pressed to the lesion to produce the immediate cover up. This is particularly helpful to hide the vitiligo lesion temporarily. That means some dyes are used, that is dihydroxyacetone or indigo carmine. This type of dyes are used, or iron oxide particularly to usually applied over the vitiligo lesion to hide the vitiligo lesion temporarily. It is for the temporary purpose, temporarily. And lastly, the psychological support, which is the most important, and that is because it produces immense anxiety and depression to the patient. So you have to proper counsel the patient, and also you have to told that if you come to the physician early, the treatment will be, the treatment can be given, proper treatment can be given. It is not a contagious disease. It cannot spread from the one person to another person. It is basically an autoimmune disease. So if it produces a lot of anxiety and depression, so you have to proper counsel the patient also. So psychological boost up or psychological counseling is also very much important. So the treatment purpose of vitiligo is the most important. For localized lesion, as I already told, the topical steroid, topical calcineurin inhibitors or topical puva therapy can be given. Apart from this, the topical JAK inhibitor, that is tofacitinib ointment, can also be applied. For extensive disease or rapidly spreading disease in the adult and children both, we have to give the oral corticosteroid pulse therapy for several weeks. If there is any contraindication, suppose the patient is diabetic or hypertensive, in that case other immunosuppressive can be given like methotrexate or azathioprine or oral JAK inhibitor, particularly in the adults. And after stabilization of the lesion, both adult and children, narrowband UVB can be given. Systemic was particularly given to the adult patient or the person with more than 12 years of age. And for the other aspect of the treatment, for segmental vitiligo, usually produces poor response to medical treatment. The surgical treatment can be given, excimer laser and the camouflaging. These are usually the treatment aspect you have to know.